and recommendations, assessment, development, and evaluation, or GRADE working group. His main research areas include guideline development, evidence synthesis, implementation of best practices, clinical epidemiology, and health research methods development. So we'll welcome Robbie to the podium. Thank you.
Thank you very much for this introduction. Just making sure, can you hear me?
Yeah.
Good. Let me share my screen.
I hear you loud and clear.
Great. Okay. So thank you very much for this invitation to present at the symposium. So as I was introduced, so the presentation is about the impact of the Canadian guidelines for post-COVID-19 condition, or CAN-PCC, on practice and research. So here you see my disclosures. They've been mentioned in the introduction as well, so I won't spend too much time on it. I do want to mention that CAN-PCC was done with a financial contribution from the Public Health Agency of Canada. So the objectives of this presentation are to describe to you the uptake and impact of our recommendations, as well as the knowledge mobilization tools and activities. To summarize research gaps identified for questions prioritized in our guidelines, and to provide suggestions for enhancing the uptake of the CAN-PCC recommendations, as well as to provide suggestions for prioritizing research to improve the body of evidence for long COVID. Here you can see in 2022, Dr. Mona Niemer, the Chief Science Advisor of Canada, reported in their report, as priorities establish PCC diagnostic criteria, standardized assessments, and clinical practice guidelines based on consistent definitions in collaboration with national and international partners. And so we started CAN-PCC shortly after in 2023. And still in the report in 2024, she mentioned while scientific studies are undertaken and the evidence base grows to fill knowledge gaps and inform practice, individuals living with PCC or long COVID require care, support, and treatment now. So you can see here the importance of having guidelines. So we started CAN-PCC, and we collaborated with over 150 persons, primarily in Canada, but also internationally, who were health professionals, persons with lived experience, as well as their caregivers, policymakers, health economists, and researchers. And together they combined expertise in long COVID and related care, guideline development, evidence synthesis, knowledge mobilization, so implementation, as well as evaluation of the impact. And as I said, our project started in February 2023, and it was completed in March of this year. Here you can see a simple overview of the key methods and processes that we have used. We presented this also in many other webinars and other opportunities to present. So here I will keep it relatively brief. So we used evidence-based systematic approach. We used an open call for participation as well as for input. We had equity considerations front and center, or as a very important part in all steps of our project. We transparently are reporting our methods and our outputs, which are recommendations and tools. Our key groups and collaborators were from Canada as well as internationally, and I will explain a bit more about that. And we had independent conflict of interest management, which is very important when you develop guidelines. And the final point is we used standardized training, so everybody involved in guideline development had the same understanding of the methods and the steps that we had to go through. Here you can see that in total in CAN-PCC, we developed 102 recommendations and good practice statements. You can see here the 6 topics for which we did this. So it's for prevention of long COVID, testing, identification and diagnosis, clinical interventions, neurological and psychiatric topics, pediatric and adolescent topics, and also healthcare services and systems and social support. And you can see here just a quick representation of our recommendation map, which is on our website. So if you go to our guidelines, you can find an overview of all the recommendations we've developed. So all 102 are there. And this is the map view. We also have a list view, but in the map view, you can also filter based on the topic, based on the specific group of patients, or based on the specific intervention or test. So please do check it out if you haven't yet done that. So after or with development of our recommendations, we also developed knowledge mobilization activities and tools to get them taken up, disseminated and taken up in practice. So as a central team, as I said, we had our website and our rec map, our recommendation map, which also contains plain language recommendations or plain language versions of our recommendations. We sent out tailored emails to anyone who wanted to be informed about them. We had press releases. We used videos with explainers as well as some graphics. And in terms of, and to go back, we had social media posts and webinars at conferences. And we also supported separate knowledge mobilization projects that addressed different parts of Canada, as well as different groups that would benefit from using or receiving care based on the recommendations. So these 6 selected topics were policymaker information kit. We expanded on My Guide, which was an established program already to get care into practice. We had a continuing professional development course for physicians, an interactive infographics. We had a training program for health professionals to reach migrants and refugees. And we had accredited webinars, infographics, and outreach visits. All of this was done to, again, disseminate and get our recommendations taken up in practice. As an evaluation part for the project, we looked at the online interactions, so social media, clicks, impressions. We looked at the use and views of our website and our recommendation map, as well as we looked at the uptake of our tools and activities, awareness and knowledge of our recommendations, the attitudes and intentions to use, and accessibility and barriers to their use. We also did an internal evaluation of our own processes and methods with our collaborators. So these were the different components of the project that we've performed. So I want to show you a bit about the dissemination and impact. Here you can see in terms of online engagement, for our website had almost 60,000 views during the project. And you can see underneath in blue, since then, until now in October, we had 25,000 more. But more importantly, our recommendation map, which had 22,000 views during the project, had another 40,000 views since the project ended, so since April. And you can see there's still a lot of attention for our recommendations, and people are still looking at our website and looking up our recommendations on the rec map. In terms of social media, we had 631 posts on Facebook, LinkedIn, and X, and we had 123,000 impressions and reach together, which is content displays and unique users. Finally, we sent out 30 newsletters throughout the whole project with updates on our project, and as well as alerting them to our subscribers to new recommendations. And we had over 2,000 subscribers. 39% of them were persons with long COVID. And the open rate of these newsletters was 57.6%, which is well above the non-profit industry average, as you can see, which was 40. So we reached relatively many people using our newsletters. About active outreach to organizations. When we started our project, we were actively engaged with and collaborating with 15 partners at the beginning of the project. And during the project, by active outreach and also by outreach through our collaborators that we were working with in our guideline groups, we managed to connect with over 350 organizations, which includes healthcare organizations, allied health organizations, patient-centered groups, as well as equity-seeking organizations. And you can see some examples here. And of course, I won't go through the details if it's 350 plus. But you can see how this was really used as one way to get our message out, to get our recommendations out. So our targeted activities, so EBM Connect on the top left is the program that was aiming to reach refugees and migrants. For that program, there were 154 practitioners reached, and 19 completed their fellowship, and 19 equity-seeking communities were reached with our recommendations and our tools. In terms of webinars, we had 10 CME, so continuing medical education webinars, as well as 7 non-CME webinars, with together 826 attendees. We attended the Family Medicine Forum in 2024. So our staff went there and had support from the people, our collaborators in BC. And we had 120 participants, physicians attending our booth, and 12 family medicine connections were made there who were interested to receive our recommendations and our tools. And in terms of conferences, we attended 8 conferences, gave 14 presentations on our work, with a total of over 2,500 attendees. Here you can see a bit more about the effects of our outreach and outputs. So we, based on what I just showed you, what we did for the project, we also had 11 invited presentations based on people finding out about what we were doing. And these presentations had 623 attendees. We had several organizations in Canada that posted links or some information or recommendations on their website. So you can see here 6 provincial websites, as well as Long COVID Web as well. So thank you very much for that. And we still also had another 10 invited presentations since the project ended after March, as you can see here. And these were to the global Long COVID webinar series supported by the Schmidt Initiative for Long COVID, which is SILK. Finally, we have international reach. So we shared our methods and outputs with several organizations that we collaborated with and who were interested in our list of questions, the evidence that we found, and how our approach was to provide recommendations, including WHO and some other large international organizations, as well as the Post-COVID Network Netherlands that we presented to recently. Here you can see what we are publishing and planning to publish. We've had 2 press releases by McMaster. We've had articles on CBC News, Hamilton Spectator, and the Toronto Star recently. We've submitted our guideline manuscripts, which will be a total of 8 plus 1 methods manuscript to the Canadian Medical Association's journal. And we are planning other publications on methods, as well as systematic reviews and tailored summaries and explainers. Now here you can see a snapshot of our evaluation. So we also did evaluation by reaching out to a larger group of people in Canada to get input on how well they are aware of our recommendations and our guidelines, what their attitude towards is, and if they're planning to use it, for example. And you can see here the left columns for healthcare practitioners, and the right is for the public. So 59 and 257 persons responded to our survey. You can also see that 50% of the healthcare professionals and 91% of the public members who responded have lived experience with long COVID. Their awareness of the guidelines of CAN-PCC was 55% and 59%. Based on the question, if they think CAN-PCC or guidelines are necessary, almost close to 100% would say yes, 93, 94%. If they were planning to use the guidelines in practice, or if they are using the guidelines in practice, 68% of healthcare professionals said they were. And among the public, 34% said they were using it, which means they took our recommendations or the plain language versions or any of our tools to inform their conversation with their healthcare provider. We also asked if the healthcare providers initiated discussion about the CAN-PCC recommendations, and among the public members, 5% said they had that. They said yes, that their healthcare professional initiated that with the CAN-PCC recommendations. So still, it's quite a low percentage. And finally, we asked if they accessed our knowledge mobilization products and tools that further can help with understanding and implementing our recommendations. And healthcare professionals said in 15% of the cases that they did access that, and the public, for the public, this was 24%. So here's some suggestions in terms of the use of our recommendations. The CAN-PCC structure and the transparent reporting allows for continued impact. And you can publicly share the available recommendations and knowledge mobilization resources in English and French. It's all available. Everything's there. Anybody can access it and share it. Can use it as a resource for continuous updating with emerging evidence. Also there, the whole infrastructure is set up. You can use it as a resource for adapting recommendations to local and international contexts. So some of the international organizations are actually working on that to adapt it for their own purposes. And you can involve project experts with understanding of priorities and evidence in continued work. So our collaborators are all still very motivated to continue this work after having set this up. So then a bit about the impact of CAN-PCC on research. I first have to do a short recap of some of our methods, and I think many of you have seen it before, but I think I'll do the recap because it's important to then discuss what we can learn from CAN-PCC. So here you can see one graph that indicates when we issue guideline recommendations that there is a strength and a direction to it. And so recommendations can be strong against an option, an intervention, or a test, or strongly in favor. However, they can also be conditional against an option or conditional in favor of an option. And this was the case for most of the recommendations in CAN-PCC. And you can see the middle option is also there, that it's either or. You can either use the intervention or alternative. This is not very common, but sometimes you may end up with that. But hopefully this is clear. There's a strength and there's a direction. So for or against, or strong or conditional recommendation. Now, conditional recommendations are typically issued when there's low certainty or very low certainty in the evidence. And first of all, what does it mean, certainty of the evidence? The certainty of the evidence, as you can see here, the definition underneath the illustration, it reflects our confidence that the results are in a particular range or above or below a certain threshold. This is primarily for health effects. And you can see we assign it as very low, low, moderate, or high certainty. And it shows what that means in terms of assigning that certainty. We also have these tools on our website available to explain more about this. So I recommend that you look into that if you're interested to learn more about it. But this certainty is very important. And we assess the certainty using the grade approach. And this is based on different domains, as you can see here. I won't go into all of them because that will take too long. And I really want to focus here on one specific example. So one thing that we assess is indirectness. So we systematically look for research evidence, and we assess, is there evidence available for the population that we are specifically interested in, for the intervention that we're interested in, or in the comparator, and also the outcomes that we're specifically interested in. If not, there may be other evidence we can use, and we may call that indirect evidence, but it still helps us to make a recommendation. Now here you can see in CAN-PCC, and this is an analysis among 71 of our recommendations. It still needs to be finalized for all our recommendations. But these 71 recommendations included a total of 889 outcomes that we assessed for which we looked for evidence. And you can see the majority had very low or low certainty. So 68% and 20%. Only 5% had moderate certainty, and only 1% had high certainty in the evidence. So you can see most of our outcomes for the recommendations that we addressed have low or very low certainty evidence. If we specifically look at indirectness, and this was an important factor, we can see that in 47% there was no issue, no indirectness. However, in 53%, so when there was serious or very serious indirectness, which means We used evidence from another population or for another related intervention or outcome, still being informative, but it makes us a bit less certain, so we considered it somewhat indirect. And I'll give you some examples of what that means. I, of course, cannot go over all of them, but here you can see, for example, for the population, we had a question about low-dose naltrexone. We did not have comparative studies in long COVID, so we were advised at the beginning of the project to look for other evidence from other related conditions, and we found randomized controlled trials from fibromyalgia. So this is what the guideline team used, acknowledging that it is somewhat indirect. Another common example is that often for children and adolescents, there's not a lot of evidence available, and then sometimes adult evidence is used instead. But of course, as often is said, children are not small adults, so you have to weigh this option and see if the evidence is informative. If so, you may use it, but acknowledge that it's somewhat indirect. One more example here, persons with any condition may have been included in the study, but it can still be helpful to figure out if certain health services like support care at home, for example, can be used also for long COVID, the context of long COVID. Then we have the interventions. The fibromyalgia, I already shared that with you, the comparison. So we had one specific example from our testing and diagnosis guideline team, whereby they looked for evidence whereby we can say, what's the effect of testing versus not testing? But they found evidence of long COVID patients versus healthy controls. So that was an indirect comparison that was still helpful to make a decision. Often we did not have a comparator that's usual care because it wasn't really clear what usual care is at the moment for long COVID. And I'm sorry about the slide here, but for the outcome of interest, sometimes we were interested in the diagnosis of long COVID, but we only found evidence in terms of effects on the symptoms that are associated with long COVID, but not the diagnosis itself. So this is how we try to manage that by still using useful evidence while acknowledging it's not precisely or directly what we were interested in. So in terms of research, we also have research recommendations, which means there's insufficient evidence to make a health decision for practice. So in that case, we gave a in research only recommendation. And this also means further research may increase the certainty at acceptable costs, as far as we think. And this was provided for these topics you can see here on the screen. I won't address them specifically here, but you can find them on the recommendation map. So to wrap up the research part, so in terms of considerations, CAN-PCC's general findings include important considerations. So we need funding, of course, for those research recommendations, first of all. They're prioritized questions, they're important, and we need to address them. And there was no evidence that was useful to make a practice recommendation. You want to focus on the most important questions in practice and specific populations in general, so this may have to be updated once in a while. You want to prioritize on outcomes that matter most to patients and caregivers. Observational comparative studies can be helpful. Not everything requires a randomized controlled trial. So if you can do a well-done observational comparative study, please do. But of course, when you do a trial, make sure it's sufficiently powered and it detects a meaningful difference in terms of outcomes that are important to people. And finally, international collaboration can improve efficiency as well as relevance of your findings. So check our research considerations, which we provide in the evidence to decision framework for every recommendation that we post on our recommendation map. Okay, so that was maybe quite a bit. To wrap up this presentation, CAN-PCC has had and continues to have a Canada-wide and international impact. It provides an ideal overview and starting point for long-term evidence-based approach to long COVID, to management and prevention of long COVID. And the guidelines provide valuable insights for researchers. Limitations of what I've presented to you here is that it's descriptive analyses, and of course the evidence for recommendations needs to be updated, which is part of what we are advocating for. We want to continue this work so we can keep updating the recommendations. And as a final slide, I want to show to you here our great collaborator, Kimberly, who is a person with lived experience, recommends to use the guidelines. And I think she represents many of our collaborators who really are proud of the work we've done and want to continue with. And I want to acknowledge everybody who's worked with us in CAN-PCC, everybody who's provided feedback on our various calls for input. Really appreciate it. And many of them are also part of the Long COVID web. So thank you very much. And with that, I will open it up for questions.
Thank you very much, Robbie, for that great comprehensive presentation and for your hard work in CAN-PCC. It's certainly a valuable tool and a lot of work has gone into it. So now I'll open up for questions, both in person and also virtual. If you'd like to, you have the podium, you can start first. Thank you.
Testing. Hi, Robbie. Thank you so much. My name's Kaylee Jamison. I'm a patient and researcher who contributed feedback to the formation of your guidelines. However, I, along many long haulers who contributed, felt our feedback went unheard despite using our limited energy to contribute of our lived experience, especially medical practitioners. So how would you like to respond to patients who felt dismissed in this process, with many reporting they end up giving up contributing feedback, which result not witnessing changes? As a follow-up, I also would like to ask what led to the methodological choice of forming these guidelines around low versus high certainty, as if a heavily stigmatized condition like long COVID and the medical environment dismissal poses further barriers to convince primary care providers to adopt recommendation when there's a label of low certainty. Thank you.
Yeah, thank you for those two questions. So to get to the first one first, so I understand it takes time and energy to respond to our calls for feedback and input. So I think everyone who did it, we did get many responses actually consistently over the whole project. There was no slowdown in that sense. So that was really good to see. We did gather all the responses, summarize the main themes from them, brought those to the guideline development group and guideline team, which then considered what they needed to clarify or update or change based on the feedback. And we've had a couple of examples where this was used, it was brought back, they needed some more time to make those changes, or at least to discuss potential changes, and then it was released later. So it's not that we definitely looked at the feedback, at the comments. It may not, perhaps we could have been better at communicating how exactly that process worked, but we did do that. And then the second part is regarding the certainty. So the way we approach this, and this is based on the GRADE methodology, which is the most widely used methodology for guideline development, is you prioritize questions and topics that are considered most important, most critical for this population and for long COVID and the specific topic that you want to work on. That means they're very important questions, not just for patients, but also for practitioners, and they need guidance to manage or make decisions, health decisions. So if you then look for the evidence and you have, let's say, not a lot of evidence, it's still an important question. You still need to be as good as possible, provide a recommendation. And that's why but you cannot pretend that you have high certainty evidence. You cannot pretend that it's all resolved if you have only one or a few small studies. So we are very transparent about that. We look for the evidence, we say this is low certainty, we explain all the decisions that we make and still make a recommendation based on that. But of course, the message with that, hopefully is also clear based on my presentation, is that additional and future research is needed to make that firmer, to make us more certain that what we are recommending is indeed the best option. But not giving a recommendation does not help anyone. Because for long COVID, especially in the beginning, there was very little evidence to go by, and then there would be no recommendations at all.
Thanks for your response. The one thing I want to say is perhaps it's the framing of such recommendations of like a red versus green light. And if we are taking a knowledge mobilization approach, I strongly consider you to take more patient experiences and the reports of the mixed reviews of CAN-PCC into account. Thank you.
All right,
Thank
thank you. Yes. Susan, do you have some online questions?
Yes, there's a few. We're just wondering if, Robbie, you could stop your presentation so we can see you. That's
Sorry.
better. Thank you.
Yeah.
Nice to see you. So you mentioned that you're still seeking research funding to continue this work, but without that funding, will there be any sort of updates or reviews or continuation of the work, or will it end here? And will, if the work can continue, will there be any adjustments in the methodologies?
Thank you, Susan. So the project officially ended after March. We have been doing additional work since to get more of our recommendations published that we were already working on to now get our publications out to present to other groups like we're doing here. So we are very keen on continuing that, but we have been applying for additional funding to continue the work to look at emerging evidence and incorporate that and keep updating these guidelines, which is, I mean, the hard work has been done now. This was a lot of work, but now everything is there to be adjusted, updated as needed. And so we're looking for that, but right now, because of the lack of funding, we are not working on that right now, unfortunately. But again, we have applied for funding to do at least certain parts of this work. And oh yeah, you also mentioned any changes in the methods. I think we do have to learn, of course, from this project. The guideline development methods, these are the best available methods that people are using for guideline development. But I think we can learn a few things in terms of how to communicate, how we are using the feedback, as the previous question addressed, making sure that people have enough time to provide feedback. And yeah, we have to evaluate our processes to make sure all the voices are appropriately represented within the project. I think we did pretty well in CAN-PCC, but of course there are always things to improve.
Okay, thank you. Do you have a question?
Yes. Hello, nice work on this and congratulations on your work. I'm a PhD student. My name is Stefania Spin and I'm working on biomarkers for long COVID. So I had a question related to the indirectness that you mentioned that, for example, the outcome is related to persisting symptoms, but there's no confirmed diagnosis of post-COVID condition. So I was wondering, what are you considering the confirmed diagnosis of post-COVID condition? It must be maybe my ignorance. I'm on the basic research, not on the healthcare. But we made a qualitative study where we interviewed clinicians as well as patients, and both of the groups had the idea that there is no like official diagnosis of post-COVID condition for the healthcare system and also for support policies for patients. So what are you considering like the confirmed diagnosis? Because I think this is like a main limitation for patients to access care and also to develop policies to support them.
Yeah, thank you. Great question. So when I mentioned that example, it was mainly for our prevention guideline team who were interested in different types of interventions like masking, ventilation to prevent COVID-19 infection and thereby long COVID. So they would be interested in, okay, how many cases of long COVID can we prevent? For that purpose, that's why I mentioned it, but you're right, there's no one let's say, clear diagnostic definition, because our testing and diagnosis guideline also indicates that most of the tests are useful to exclude other causes. There are, of course, the WHO and other case definitions. There are healthcare systems like in Ontario, they have a diagnostic code for healthcare professionals to use. But what exactly their definition is when they enter that, we of course don't know. So I think it's a fair question. We don't have a clear definition right now because there's no clear set of diagnostic tests that confirm that. But the example is mainly to illustrate that we are interested in that specifically. We have to prevent long COVID, not just one symptom that's associated with long COVID. So it was just to illustrate how we use that evidence, but it's not the same as, you know, if you look at one symptom like chest pain or dyspnea, it's not the same as looking at the whole condition necessarily.
Okay. Thank you. Thank you.
Thank you.
Susan, do you have any more online questions for Robbie?
Yes, I can ask this one. What is the practice standard obligation for physicians once these guidelines are out there? How do we ensure that there's more awareness? I know you're working hard on that, but is there anything else that could be done? And what happens if they're not following professionally developed evidence-based guidelines? Thank you.
Yeah, thank you. The guidelines, whether they are mandatory, I guess, for healthcare professionals, that's sort of the question. This really depends on health policymakers and authorities, whether they want to make the guidelines or certain recommendations mandatory so that people have to follow them. It's not, you know, we provide the recommendations, of course, for implementation in a wide variety of settings. But we, as the guideline developing group, cannot force healthcare professionals to use them. But of course, we're doing our best to explain that this is the best they can work with, because nobody else is going to take all that time and work with such a large group to look at the available evidence and create actionable recommendations that will hopefully benefit them in practice. But we cannot force healthcare professionals to do that. You need the authorities to sort of make that mandatory if that's what you're looking for. Sorry, was there another part to the question? Maybe I forgot.
That's great. Thank you. And thanks again, Robbie. That was great. So we're
Thank you very much.
Thank you.